Hi everyone, this is your PowerPoint voiceover on pneumonia. We'll be talking about patho, risk factors, diagnostic tests, and various nursing interventions. So beginning with patho, remember that it is caused by excess fluid in the lungs resulting from an inflammatory process. The inflammation can be triggered by many infectious organisms and also by inhaling irritating agents. So the inflammation occurs in the interstitial spaces of your lungs, the alveoli, and often the bronchioles. Now the process begins when organisms penetrate the airway mucosa and multiply in those alveolar spaces. White blood cells migrate to the area, remembering your inflammatory process. So the white blood cells gather in the area of infection, causing capillary leak, edema, exudate, and the fluid collects in and around the alveoli, and then that causes alveolar wall thickening. And both of those processes decrease gas exchange. So one of your priority nursing diagnoses is going to be impaired gas exchange. That can lead to hypoxemia that interferes with oxygenation, and that can eventually possibly lead to death. And red blood cells and fiber move into the alveoli and the capillary leak in the lungs. Septicemia can often result if the organisms go into the bloodstream. And if the infection extends into the pleural cavity, empyema or a collection of pus in the pleural cavity can result. And the fibrin and the edema that happens causes lung stiffening, decreasing the compliance of the lungs, the flexibility, and decreasing the vital capacity. And atelectasis, or the collapse of the alveoli, further decreases the ability of the lungs to oxygenate the blood moving through it. And as a result, the oxygen levels decrease, causing hypoxemia. Now, this is included in your PowerPoint. I'm not going to go into too much details, but make sure you understand the inflammatory process. So again, the patho, you have some microbes entering, multiplying in the alveolar space that causes damage, edema, inflammation, the migration of the white cells, fluid collects that leads to decreased and reduced gas exchange and hypoxemia. The infection can spread, and it can cause further alveolar and bronchial damage, decreased surfactant production, atelectasis, and eventually it can cause consolidation. Now there's different categories of pneumonia. I'm going to try to simplify it a little bit for you. Community acquired, it's in the name. It is contracted outside of a healthcare setting, so it happens within the community. Most often it's caused by strep pneumonia, H. influenzae, or respiratory syncytial virus, RSV. And when someone comes into the hospital with community-acquired pneumonia, you want to initiate antibiotics. Some of the risk factors for your community-acquired pneumonia: either the very young or very old. The very young, because the immune system has not yet developed fully, so they can't fight off an infection. And in the very elderly or very old, the immune system has been worn out, essentially. If you've never received the pneumonia vaccine, or it's been more than 5 years ago, if you didn't get the influenza vaccine, if you have any underlying chronic disease, any cardiac issues, diabetes, any pulmonary disease like COPD or asthma, if you have impaired nutrition, if you're immunocompromised and you can't fight off the pathogen, and smoking and using tobacco is also a risk factor because your cilia in your lungs don't work as well to help keep the lungs clear, and that can also, smoking can also lead to COPD as well. So there's healthcare associated and hospital acquired pneumonias. Healthcare, the only difference really between healthcare acquired or hospital acquired is that healthcare associated occurs less than 48 hours after someone has been admitted with the risk factors. And they might have been a resident of the nursing home, they might have gotten IV therapy, they might have gotten chemo, and they also might have a lot of multi-drug resistant organisms, MDRO, like MRSA. So hand hygiene is critical to help prevent the spread. So healthcare associated pneumonia is occurring less than 48 hours after admission, versus hospital-acquired pneumonia is pneumonia that happens over or greater than 48 hours after admission to the hospital. But most places will kind of categorize the healthcare associated and hospital acquired pneumonia in the same category. Again, we're going to encourage proper pulmonary hygiene and hand hygiene. Okay. Various risk factors. If you're an older adult, if you have chronic lung disease, if you have altered level of consciousness, if you recently aspirated, or you have poor oral hygiene, because that can cause colonization of the oral mucous membranes with a lot of respiratory pathogens, and that can be aspirated into the lungs. Certain medications like antacids, H2 receptor antagonists, and proton pump inhibitors may allow for gastric bacteria overgrowth and the development of bacteria. If you have things like NG tubes, if you've been supine for a long time, that can not only increase your aspiration risk, but it can also increase respiratory pooling. And the last category is ventilator-associated pneumonia, someone that has been on a ventilator. Pneumonia onset and diagnosis within 48 to 72 hours after an intubation. The ET tube increases pneumonia risk because it bypasses the protective airway mechanisms and allows aspiration of secretions from the oropharynx and the stomach. So we need to elevate these vented patients head of the bed 30 degrees. We need to make sure that we're doing a weaning assessment. We're properly doing DVT prophylaxis, meticulous oral care, suctioning, and again, hand hygiene is critical to prevent the spread or cause of pneumonia. As part of our assessment for these patients, we're going to observe the general appearance of how they look. Many patients with pneumonia have flushed cheeks and they might appear anxious. They might have chest pain, discomfort, myalgia, headache, chills, fever, cough, tachycardia, dyspnea. They might have hemoptysis or sputum production. And they might have chest muscle tightness or pain from sustained coughing from the pneumonia. We're going to observe the patient's breathing pattern, position, and use of their accessory muscles. And if they're hypoxic, they might be uncomfortable in a lying position and will often sit upright, kind of balancing themselves with their hands in a tripod position. We're going to assess their cough and the amount, color, consistency, and the odor of the sputum that might be produced. We might hear crackles. We might hear wheezing. We might hear bronchial breath sounds over areas of density or consolidation. And tactile phremonus, that might be increased over areas of pneumonia, and percussion might be dull. And then in looking at vital signs, we're going to compare with their baseline. Patients with pneumonia can often be hypotensive with orthostatic blood pressure changes as a result of vasodilation, dehydration, especially in the older adult. They might have rapid weak pulses because of hypoxemia, dehydration, or sepsis or shock. They might also have cardiac dysrhythmias because of cardiac tissue hypoxia. Okay, again, I just kind of talked about the signs and symptoms already, but the tachypnea and dyspnea might be due to stimulation of chemoreceptors, increased work of breathing as a result of decreased lung compliance or anxiety and pain. Hypoxemia might be due to alveolar consolidation. Cough due to fluid accumulation in the trachea or bronchi or bronchioles. Sputum due to the inflammatory process in which the fluid from the pulmonary capillaries and red blood cells move into the alveoli. They might have a fever. They might have pleuritic pain due to inflammation of the parietal pleura that causes pain on inspiration. And in older adults, one of the hallmark symptoms and early symptoms might be acute confusion. They might not show with a lot of these more common signs and symptoms. So with the older adult, we really need to assess their mental status. Again, you have this nice picture here in your handout of the overall symptoms and what they might present with. We also need to do a psychosocial assessment because the pain, fatigue, and dyspnea might create anxiety. We need to allow for frequent rest periods between activities as part of our nursing care, and we need to take things slowly. How do we diagnose pneumonia? Sputum culture for gram stain culture and sensitivity. We do want to get the sputum culture as soon as possible, the actual sample, before starting antibiotics, but we do not want to delay treatment waiting for results. So we want to get the sputum as soon as possible, and then we can start antibiotics. We don't necessarily have to wait for the results. We're going to look at the CBC, looking for elevated white cells, shift to the left. Their BU and creatinine might be high because of dehydration. They might also have hypernatremia, also due to dehydration. We might check ABGs for hypoxemia. Blood cultures, did the infection invade the blood? Are they septic? The chest x-ray is the most common diagnostic test for pneumonia, but unfortunately it might not show changes until 2 or more days after manifestations are present, and they usually look at areas of increased density that might involve certain segments, certain lobes of the lungs, or both lungs. And in older adults especially, the chest x-ray is really important because, again, their symptoms are often vague. They might just show with altered mental status. We can also do other tests, transtracheal aspiration, bronchoscopy, direct needle aspiration, or thoracentesis if they have a pleural effusion. A little bit deeper into the bronchoscopy, it is a direct visualization of the larynx, trachea, and bronchial tree, where they insert a scope with the light down the trachea after they give a local anesthetic. It can be inserted through the nose or mouth. It can also be used to obtain a biopsy or aspirate blood or secretions. They need to be NPO at least 6 to 8 hours prior to the procedure. It's an invasive test, so they need consent. They need to remove things like dentures and give proper oral care. They might need to be pre-medicated, and they might receive prophylactic antibiotics as well. Post-op, we want to emphasize no coughing because they might start to bleed. They're going to be NPO for at least 2 hours until the gag reflex returns. We're going to assess for signs and symptoms of bronchospasms, chest pain, wheezing, shortness of breath. And their sputum might be blood tinged afterwards, secondary to a biopsy or the culture that might have been taken. But if there's any frank blood, you need to call the MD. As part of the treatment and pharmacology, we are going to give antibiotics depending on the age group of the patient, comorbidities, and what the actual organism is. They might be put on a macrolide like azithromycin, erythromycin. They might be put on tetracyclines like doxycycline or cephalosporins. Bronchodilators to open up the airways, mucolytics and expectorants to get rid of those secretions, corticosteroids to help suppress the inflammation, and we are only going to give antitussives only if the cough is non-productive. We don't want to hold on to those secretions. So antitussives only if the cough is non-productive. NSAIDs for pain and increase that oxygen. So the key to effective treatment of pneumonia is eradicating or getting rid of that infectious organism. So we want to start antibiotics hopefully within 4 hours of the diagnosis. That can greatly improve their outcome. Again, we want to get the sputum sample as soon as possible, but we don't necessarily need to wait for the results to start antibiotics. So we can treat them empirically first, and once the culture comes back, then we might be able to give more targeted therapy. We might start with cephalosporins or macrolides, and once we get the cultures back, we might be able to give bacteria-specific antibiotics. Usually, anti-infectives are used for 5 to 7 days for a patient with uncomplicated community-acquired pneumonia, and maybe even up to 21 days for immunocompromised patients with a hospital-acquired pneumonia. So what are our priority nursing issues? Impaired gas exchange because of the decreased gas exchange at the alveolar capillary membrane. They have a potential for an obstructed airway due to the secretions, muscle weakness, fatigue. They also are at risk for sepsis. So what do we do for these patients? Interventions are going to be similar for your chronic airflow limitation patients. We want to provide oxygen. We want to encourage incentive spirometry to facilitate deep breathing and stimulate coughing. Cough and deep breathe every 2 hours. Positioning, have the bed up. High Fowlers promotes lung expansion. Chest physiotherapy. It helps to loosen secretions. They will be placed in various positions to help mobilize those secretions by percussion, vibration, postural drainage, and suctioning. We're going to monitor pulse ox. Maintain adequate hydration to help thin those secretions. That will make it easier to expectorate. So maybe if they don't have any reason for fluid restrictions, we might even increase it to 2 to 3 liters per 24 hours. And monitor eyes and nose. And definitely no smoking. Preventative measures, they're primarily aimed at those who are at increased risk for pneumonia. Immunizations or vaccines are key, the pneumococcal vaccine, and also the flu vaccine as well. We're going to encourage patients to cough and deep breathe, use Voldines, especially those that are post-op or bed rest patients. Avoiding crowds in the fall or winter months, especially in the elderly or immunocompromised. Stop smoking, balanced diet, especially increasing protein for healing, and adequate hydration to help thin those secretions, adequate rest, and assess swallowing to see if there are increased risk for aspiration. We're going to follow aseptic procedures as healthcare professionals, hand wash, hand wash, hand wash. And you can also look at IGI chart 31.3 for patient and family education. And one of the vaccines we can give is the pneumonia vaccine. The PPV23 includes antigens from 23 different types of organisms. And adults over 65 and anyone with chronic health issues should be vaccinated. And patient education about vaccination is important in the prevention of pneumonia. Nurses should encourage people older than 65 and those with chronic issues to receive a vaccine against pneumonia. Those with chronic issues may also benefit from a second vaccination if more than 5 years have passed since the first dose. And because pneumonia often follows the flu, especially in older adults, we urge everyone to receive the seasonal flu vaccine as well. Pneumocystis carinii is specific to immunocompromised patients like AIDS, those getting chemo or on immunosuppressants or transplant patients. That's a specific type of bacteria. And we treat with sulfa drugs like Bactrim. And the last type of pneumonia we're going to talk about is aspiration. Who's at risk? Greatest risk factors include anything that decreases your cough or gag reflex. It generally occurs from food or stomach contents. If the vomitus or stomach contents, if it is that, then the acidic substances can cause widespread inflammations, which might lead to acute respiratory failure and permanent lung damage. So you might vomit food or stomach contents that causes an acidic environment, that causes inflammation, causing edema, and ultimately respiratory failure. We generally treat it with antibiotics for a bacterial infection and give steroids and anti-inflammatories to decrease the inflammation. Aspiration pneumonia interventions focus on preventing lung damage and treating the infection. So again, antibiotics, steroids for inflammation, NSAIDs for pain, supportive care, and treating underlying issues. So we really need to assess their cough and swallowing and gag reflex for these patients. And that about draws our voiceover to a close. Hope you all have a good day.